I am Dr. Amy Case, the Chief Medical Officer at the Pulmonary Fibrosis Foundation, and I am so glad you joined this session today. Now, I would like to welcome our speaker for this session, Dr. Sydney Montesi. Dr. Montesi is a clinician researcher, in the Division of Pulmonary and Critical Care Medicine at Massachusetts General Hospital in Boston, Massachusetts. She specializes in the care of patients with pulmonary fibrosis and other forms of interstitial lung disease. Her research focuses on the use of novel imaging techniques to assess disease activity and treatment effect in pulmonary fibrosis, and the conduct of clinical trials for evaluation of new therapeutics for idiopathic pulmonary fibrosis. I'm so glad to welcome you today. Thank you for joining us, Dr. Montesi. I'm so excited that our audience gets to hear from you.
Thank you so much, Amy, and it's really a pleasure and honor to be here. I apologize if my voice sounds a little funny. We're recovering from a viral infection that's come through our household, so hopefully you guys can hear me okay. I have a few financial disclosures. Some of them are relevant to the talk. I do work on clinical trials for patients with pulmonary fibrosis, and I have received some funding from the government and from certain pharmaceuticals to support some of the imaging work that we're going to be talking about later. What I would like to do today is give an overview of approved medications for pulmonary fibrosis, talk a little bit about new treatments under study, and these are non-pharmaceutical sponsored studies that you may not have heard about already, and then spend some time talking about new research on the horizon for patients with pulmonary fibrosis, and share a little bit about the work that we are doing in our institution in the hopes it might be interesting to some people that are listening here. So I'd like to start a little bit about pulmonary fibrosis treatment and where we were. And this really highlights the importance of doing clinical trials. For many years, primary treatment for patients with pulmonary fibrosis, specifically idiopathic pulmonary fibrosis, was considered to be with what we term immunosuppressive therapy. And the mainstay of this was treatment with prednisone and a medication called azathioprine. For those of you who might be familiar with a medication called Cellcept, azathioprine is thought to have similar effects in terms of kind of suppressing the body's immune response, as well as the addition of a treatment called N-acetylcysteine that's thought to be an antioxidant. And this triple regimen treatment was used for many, many years before it was studied in a clinical trial fashion. And when it was studied in a clinical trial fashion, an important observation was made. And one is that patients that were randomized, so randomly assigned to receive the combination therapy, over the course of the trial, they actually had a higher probability of death than those patients that got placebo treatment. And so this trial was actually stopped early due to this increased probability of death that had risen during the time of the study. And this really shifted the field of pulmonary fibrosis to one to which we think if the immune system isn't driving pulmonary fibrosis, or I should say, if these medications that target the immune system in a certain way have not been shown to be effective or harmful, how do we think about other treatments? So if we think about what causes pulmonary fibrosis, and this can be very different from many different people, but just kind of distilling it in a schematic, we think about there's some injury that happens to the lung, and that injury sets off a cascade of different processes that activate the immune system, cause the vessels to be leaky. This allows these activated immune cells to come in to the area of injury. And then this brings in cells that work to lay down scar and will lay down ongoing scar formation. Now, this is what happens if you were to cut your hand. If you were to cut your hand, then these processes will occur, and these are part of the normal wound healing processes. But in the spectrum of pulmonary fibrosis, for some reason, these wound healing processes become overly exuberant, so to speak. And so what a normal wound healing process would be in terms of an area of injured being healed and the wound healing process stops, in pulmonary fibrosis, the wound healing process continues. And that is what creates this ongoing aberrant repair, so to speak. And so our current thought in terms of targeting patients in terms of pulmonary fibrosis with treatment are, one, how can we protect the kind of the lung itself from an injury that might set off this apparent cascade? And that's why sometimes doctors talk to their patients about ways to minimize reflux or ways to minimize getting sick or developing respiratory viral infections, trying to minimize lung injury. But then thinking about when the lung is injured and these repair processes become overly exuberant, are there ways to target them? And this is where we have our current 2 FDA-approved treatments for idiopathic pulmonary fibrosis, one of which is approved for the treatment of other forms of pulmonary fibrosis, in terms of showing here their action in the schematic of trying to rein in repair processes. So if we look at the initial data from the 2 trials that really have changed the current field in terms of the treatment of idiopathic pulmonary fibrosis, to the left, we have the results for the trial, the Impulsus trial, that looked at the efficacy of nintedanib. And it showed here that if you look over time, and what's plotted here is the change in the forced vital capacity. So when you're getting your breathing test, you take a deep breath in and you breathe out as fast and as long as you can. That whole amount of volume that comes out, that's your forced vital capacity. And if you can see and compare to patients that got nintedanib, the actual rate of decline was lower. So what I tell patients is these medications, they don't stop progression, they don't reverse progression, but they slow the rate of progression. And then if we look over to the right, this is showing a graph from the trial looking at pirfenidone. Similar effect occurred. Patients with pirfenidone had a slower rate of decline in forced vital capacity. And that's really changed the field in terms of where we are now with 2 FDA-approved treatments. And it's also changed the field in terms of where we're going, because clinical trials, for the most part, are now evaluated in patients that are on or have the opportunity to be on background therapy with nintedanib or pirfenidone. So there's been increasing recognition since those 2 studies were published in 2014 that other forms of interstitial lung disease can have a progressive course similar to IPF. And this is a really important concept. And when we think about other forms of interstitial lung diseases, we know that there are certain types of interstitial lung diseases, such as those seen with rheumatoid arthritis, systemic sclerosis, or scleroderma, that can have an appearance on imaging that looks very similar to IPF. And what data has shown us over the past couple years, that up to about a third of these patients, the numbers will vary depending on the study or the underlying disease, but roughly about a third of these patients will develop a disease course that behaves, for all intents and purposes, like IPF. And that's currently being termed something called progressive pulmonary fibrosis. And given these similarities in terms of behavior, treatments for IPF may be effective for this condition, or this phenotype, so to speak. Phenotype really referring to the behavior of multiple different entities of progressive pulmonary fibrosis. And this led to a trial that was conducted using nintedanib in patients that did not have IPF, but had other types of conditions like rheumatoid arthritis or scleroderma that had some degree of progressive disease. And the data showed that when those patients were randomized to either nintedanib or placebo, nintedanib treatment slowed the rate of decline of pulmonary function, similar to the effect as it had with IPF. And what was interesting as well in the data is that, a lot of the work in IPF has really hinged around patients having a certain pattern on their CT scan, something what we call a usual interstitial pneumonia pattern, but it really helps doctors, understand what the likelihood it is that they have IPF. But also this pattern as a whole has been associated with faster progression or worse outcomes overall. And nintedanib, when you looked at its effect on patients that had a UIP-like pattern and those that did not, it tended to have a similar benefit in terms of treatment, and again, reducing the rate of decline compared to placebo. So this is really where we are now, that these medications we have that target somewhere along this aberrant wound healing response have the ability, or have been shown, if you look at across a larger group of individuals, to be able to slow how quickly lung function decreases. So nintedanib or pirfenidone are now standard of care for the treatment of idiopathic pulmonary fibrosis. And then nintedanib is also used for progressive pulmonary fibrosis from other causes, and pulmonary fibrosis that is due to systemic sclerosis, also termed scleroderma. But what are the unmet needs? This is where the field is, but there are a lot of unmet needs that I'm sure that you all know well on this call. The current treatments, nintedanib and pirfenidone, are costly. Out-of-cost pockets can be very high. And at the current time, it's thought that people will be maintained on these medications for an indefinite period of time. They cause side effects. Anywhere from a quarter to a third or more of individuals that take these medications can have side effects. And for some, these could be mild, but for others, these could be quite debilitating in terms of gastrointestinal side effects, and already and such that they compromise quality of life. And as I said before, at best, these medications only slow the rate of disease worsening. So we have a lot of work to be done. So we need affordable, better tolerated, and more effective treatments for our patients. Additionally, I'd like to introduce this concept that an individually tailored approach is likely to be better than a one-size-fits-all approach to treatment. What we know about nintedanib and we know about pirfenidone is really a one-size-fits-all approach. But thinking about other fields like oncology, there have been great strides in improving outcomes and improving survival with information that allows the tailoring or a more precise or a more precision approach to treatment for an individual. So I'd like to shift a little bit along this concept to think about where we are going. So if you remember the slide, one of the slides I started with, it was the Panther study. And that study was the one that showed harm in the setting of prednisone and two other azathioprine, as well as acetylcysteine. However, it was thought that the burden of harm from that clinical trial was really the immunosuppressant therapies of prednisone and azathioprine. So when that study was stopped, individuals could continue on acetylcysteine versus placebo. Acetylcysteine is an antioxidant that's it's non-prescription regulated. It is available easily. And when this trial was continued, it was shown that there was no difference in FVC decline in individuals who received placebo plus acetylcysteine. However, a really interesting finding was published the following year, in which they took patients in this trial and they stratified the results based on a certain gene type. And what they found was if individuals had a certain genotype and a gene called TOLIP, their survival was actually worse with treatment with acetylcysteine. However, if they had a different gene type, their survival was actually better when they received acetylcysteine. And this is to suggest that really supports the concept that a one-size-fits-all approach may miss opportunities to detect a benefit in a smaller number of people. There is precedence for this. The whole field of treatment of lung cancer is really revolutionized when people looked a little closer at some of the data that came out in the early 2000s that led really to this advent of targeted therapy based on the presence of specific mutations in tumor. So this is really led to the concept that's just shifting from a one size fits all to a personalized medicine approach. And I'd like to introduce the precision study. When I say introduce, I imagine that there are people in this listening to this call that are participating. But this is really a landmark study for several reasons. One, it's a first pharmacogenomic study in patients with idiopathic pulmonary fibrosis. So what does that mean? It's the first time that there's been a clinical trial in which treatment is tailored to genetic information. And this is a trial that's sponsored by the National Institutes of Health. It's a phase 3 trial in which the medication N-acetylcysteine that I mentioned in the slide before is being studied against placebo for a duration of 24 months for individuals who had this certain genotype that had, on a prior analysis of prior acquired data from the trial I mentioned, had shown to have a favorable response. And the other thing that's important about this study is it's using a clinical composite endpoint. So the two treatments that are approved for IPF at the current time, they were approved after the study demonstrated efficacy at reducing the pulmonary function decline based on measuring the actual volume. So it's a numeric decline endpoint. But that may or may not represent outcomes that are meaningful to patients. The rationale for using the change in forced vital capacity has been that has been a good surrogate for outcomes that are very meaningful to patients, such as needing lung transplant or death. But this study is using a clinical composite endpoint. So it's a pulmonary function decline based on a certain amount, whether or not patients were hospitalized for a reason that was related to their breathing, or whether they underwent lung transplant, or unfortunately, whether they died. This study has completed enrollment. It's currently in the follow-up. And it's likely that these results will be made public in the next year or so once the follow-up timeframe has been completed. Going again to the other needs, as I mentioned before, and as you all know well, affordable, better tolerated, and more effective treatments are needed. EGCG is a principal component of green tea, and there have been extensive safety data that exist using EGCG for a variety of indications. And what's very interesting, there is data that this low-cost agent, very well tolerated, might be, quote, an anti-fibrotic. So this is work that was done by Hal Chapman, University of California of San Francisco. And then for those of you who may be aware, in terms of thinking about what are the main drivers biologically of developing pulmonary fibrosis, there's something called TGF-beta. And this is considered one of, or the main pro-fibrotic mediator that helps propel the ongoing development of fibrosis. At the current time, there's no treatment that blocks TGF-beta directly. And what Hal Chapman and his colleagues discovered is that EGCG can block the signaling of TGF-beta and fibroblasts or fibroblast-like cells. So fibroblasts are the cells that when they become activated, they can secrete things that are the building blocks for scar formation. And he did a study in which individuals that had pulmonary fibrosis, they were going to be undergoing lung biopsy to better understand what the cause of their interstitial lung disease was. Those individuals were administered 2 weeks of EGCG, and then when those individuals underwent lung biopsy, some of that tissue was taken to Hal's lab and analyzed. And what they found, if you look over to the right side, that the individuals who underwent 2 weeks of EGCG treatment prior to the biopsy had a marked reduction in the amount of collagen in that tissue, suggesting that this medication is having a biologic effect, and it's having a biologic effect on an outcome of an activated fibrotic process. So I've had the great fortune of being part of this study from the beginning. And this is work that's being done with Hal Chapman, Fernando Martinez, Kathy Spino, all these individuals who have been really involved in advancing the field of pulmonary fibrosis, either through basic science discoveries or clinical trials. And this is a phase 1 study that we're doing in which individuals with IPF that are on either nintedanib or pirfenidone are assigned to either EGCG or placebo for 12 weeks. And we're looking at 2 different doses of EGCG, and we're looking to assess the safety, any evidence about how the drug is metabolized in the body and any interaction with nintedanib or pirfenidone, and also looking at evidence of drug effect to see if we can have any information to suggest that this could be something that would be worthwhile moving forward in development, really to kind of address this concept of more affordable and better tolerated treatments are needed. Now, where are we going? So I had the good fortune of being part of a workshop that was sponsored in collaboration with the Pulmonary Fibrosis Foundation, the National Institutes of Health in terms of the NHLBI division, which supports a large amount of pulmonary fibrosis studies, as well as the Three Lakes Foundation. And one part of this workshop was really to think about how can we be innovative in clinical trial design to really maximize the information learned and to accelerate the development of new treatments, and also to provide opportunities for a wider, more diverse population for people to participate in the studies, given that as a whole, most studies that have come through the pipeline to date have had very, very rigid inclusion-exclusion criteria, which limit the number of people that can be enrolled in the study. They also limit the generalizability. So going back to the same themes, affordable, better treated, tolerated, and more effective treatments are needed. And really, how can we expedite the study of potential treatments for pulmonary fibrosis? And I'd like to introduce you to the concept of REMAP-ILD. And this stands for Randomized, Embedded, Multifactorial Adaptive Platform Trial for Interstitial Lung Disease. This is a concept that has been used in other areas of medicine. This type of REMAP trial was particularly useful and effective at looking at potential new therapies for treatment of COVID-19. And this application to ILD is being primarily led by Kisley Jenkins out of the UK, as well as a number of colleagues from multiple institutions across the world, and seeing how we can kind of raise awareness and hopefully build an infrastructure we can apply this to patients for interstitial lung disease. So let me kind of go through what this stands for. So R is randomized. So patients will be randomized to a treatment. In most cases, it's a treatment versus placebo, although theoretically it could be between one active treatment versus another. Embedded, meaning that as best as possible, a lot of the measurements are embedded within standard of care, which helps reduce costs and also helps make things easier for patients if a lot of the data can be collected when patients are already seeing their providers. Multifactorial, the thought would be as more treatments become available that have potential to be effective for pulmonary fibrosis, you can study multiple different treatments at once. Adaptive, meaning that if you find that treatment A is no longer helpful, you can adapt that information as you move forward. And more importantly, if you find out that treatment C does wonders for pulmonary fibrosis, well, then you can adapt the trial so that treatment C then becomes new standard of care, and then you study new treatments on the background of this new standard of care. And platform is really means that you have the infrastructure that's set up. So the stadium is built, so to speak. So every time you have a game, you come to the same stadium or multiple stadiums at different places. But once you finish a trial, you don't have to break everything down and then wait months and months and months to start it back up. But you're kind of ready to go at any one point in time. So what are the advantages of this? Well, it allows you to test more than one treatment at once. This is the multifactorial concept. Reduce cost by reusing infrastructure. Again, the analogy of keeping the stadium built, and accelerate new treatments. And then an important point is that in principle, outcomes should improve over time. Now, that hinges upon the fact that we find effective therapies that then become standard of care, and then newer treatments are added to that. And so if you add an effective therapy to an effective therapy, then in principle, over time, the outcomes for patients should get better. So here's a kind of an example of, adaptive trial design. And what does it mean to adapt? Well, really, you're adapting as new information is acquired. So, excuse me. What you can do is you can have a look early in the trial to see, okay, do you need more patients than what you already have? Because the last thing you want to do is complete your trial and really say, okay, if I had 50 more patients, then we really could have done the statistics to show that the treatment is or is not effective. So you can adjust the number of patients as needed. Again, you can stop testing a specific treatment. So if you look over here in the top row, kind of you start the trial and you find out that orange is not helpful. Well, then you stop it. And then you can define a new standard of care. So as I mentioned, if you have a new standard of care, then that then becomes the background in which other treatments are added. The other thing that I think is particularly important is that you can define a patient population or subpopulation of benefit. So if you have a new medication, you can test it in patients with ILD, and then within the ILD, the general term of ILD, you can then look at patients that have disease A versus disease B versus disease C, or they might all have the same disease, but they have maybe a different feature on a blood test or an imaging test. And you can define patient subpopulations of benefit. Again, this helps to theoretically accelerate new treatments, and also brings us a little bit closer to this concept of a one size fits all. But a one size doesn't fit all, or may not fit most, but how can we tailor treatment to individual needs? So here's an example. You have individuals that start the trial, they're randomized to different treatments, and then you have a look. And the idea would be that is there information that allows you to take a look early that really lets you know between A, B, and C that B is your winner. Now, it could either be your winner in terms of a winner for good, or B is your winner in terms of the one you want to take forward and study longer, which is probably most likely the case. But that's how you think about taking in all the information you have and then adapting or making these decisions so you can get to decisions a little bit faster, and you kind of save your resources and be able to utilize them to continue to evaluate new treatments. Another thing I want to cover that feeds in a little bit to this, but is also, I think, an important concept in terms of where we are now and where we are going, is that there's very important questions that we cannot answer that are needed for us to be able to move from a one size fits all or fits most to an individually tailored treatment. And so one of these questions is, how active is my disease? And this is a major limitation that we have, because our assessment methods, such as using CT scans of the chest, pulmonary function testing, they really provide little information on how active disease is at one point in time. They provide information looking back. So you can say that over the past 6 months, the disease got worse. Over the past 5 years, the disease got worse. Or the past 5 years, the disease was stable. But past may not be prologue. And we all know that these individual courses are very, very difficult to prognosticate. The other question that's very important is, how do I know if my treatment is working? And because these treatments, for the most part, slow disease progression, and the rate of progression is very, very variable, it is difficult, if not impossible, to determine treatment response for an individual. It's easier to do it for a clinical trial because you have a comparator arm and you have multiple patients. But for individual, it's hard. And when you're talking to a patient and you're trying to figure out, okay, are these extra costs, these extra side effects? How do I weigh that in terms of what my disease state is? I'm very limited in terms of what I can offer patients, because I don't have a test to say your disease is not active right now. I feel comfortable for your coming back in 3 months and we'll repeat test X again. I can't say that. And if I could say to a patient, your disease is quite active, I think it's really important that we start this treatment. These things are helpful. They'd be helpful to have to better facilitate shared decision making, so patients can make the best decision for them with the best amount of evidence that the provider is able to provide to them and their families. So this just highlights a little bit about the disease course of pulmonary fibrosis. Again, some patients can have quickly progressive disease. Some patients can have disease that kind of progresses at a stable pace. Some people have disease that progresses slowly. And then some people have a disease that has stable followed by periods of acute worsening. So really, how can we predict who's on this curve versus this curve versus this curve? And these have implications for patient care and clinical trials. So if we go back to what we think about what's happening in pulmonary fibrosis, there is some form of lung injury, which in the case of having an acute infection or developing COVID, that is a specific form of injury. But for a lot of people, the lung injury might be very, very subclinical. And probably for most people, it's so subclinical that we can't actually fully identify it. And then we have this kind of wheel of aberrant wound healing responses. And if we think that they are what's driving the development and propagation of fibrosis, can we assess these processes as markers of disease activity? So if you could determine how much collagen is accumulating, then theoretically that should tell you how active the fibrosis is. And so this is work that I've been doing for the past more than 2 years, several years or more, with colleagues at MGH. I have a colleague, Peter Paravan, who is a molecular chemist, and he has developed a PET probe that binds type 1 collagen. And type 1 collagen is really the hallmark of fibrosis. So when you have scar formation, it's made of excessive amounts of type 1 collagen. Our current CT scans, they can visualize the result of collagen deposition, such as scarring, but you can't actually see the collagen, so to speak. You see the structural changes. And he developed a PET probe that binds type 1 collagen. And when I say PET probe, you might be familiar with the concept of PET imaging that's used commonly to stage cancer. And patients have cancer looking for how far cancer is spread. That is used with a certain PET compound, but there are multiple different compounds that can be used with PET. And this one binds to collagen. So the thought is, if you inject this PET probe into a vein of a patient, you put them through a PET scanner, you're able to detect where the probe goes. And if the probe binds collagen, then you should be able to see that. And there's evidence in animals that this probe can detect treatment responses in mouse models of pulmonary fibrosis. And we've been doing work and completed our first in human studies. And so we have data suggests that this probe detects increased collagen in individuals with IPF. This is a healthy volunteer, and you can see the lungs are relatively unenhanced. This is the aorta, and that's why it's bright. This is a patient with pulmonary fibrosis, and you can see that there are areas of bright uptake, that it's kind of heterogeneous. This is a CT scan of the same patient, and you can see that there's a lot of scarring here, but there are areas of the lung where there's scarring and there's not increased signal, yet there are also areas of the lung where the signal is high on PET, but there's not structural abnormalities on CT. So where am I going with this? Well, we think this probe, and we have evidence this probe is sensitive to binding more recent collagen, meaning that it should really be detecting disease activity. And if that's the case, then this information should theoretically help us understand if someone's disease is active or not. I say a lot of shoulds and could because we are in the process of doing studies to try to support our hypothesis. So I don't want to over deliver, but I want to tell you what we're doing and what we think, where we think we might be headed. And this just shows that if you measure the amount of signal, the signal is higher in the lower region of the lung in patients with pulmonary fibrosis in the peripheral region of the lung. And that's what we know about the disease. So we are detecting things that make sense in terms of what we know biologically. And this is another individual with pulmonary fibrosis. This is a PET scan, and you can see that there's a lot of signal here on the upper outer of the periphery of the right lung. And there's signal that comes here above the liver. And if we look over to the same patient, this is a CAT scan that was obtained close to the time of the PET scan. And this is a CAT scan from a period before, that was about a year before. I don't remember the exact time. But if you look at here, you can see that the patient has had progression of their fibrosis. And the majority of progression has occurred right here, where these arrows are, and especially at the right lung base. And this is where we're seeing areas of high signal. And there doesn't appear to be much visual progression at the left lung base, and there's not much uptake here. So supporting that we think we're detecting something that's happened recent. And then we're in the process of enrolling individuals with idiopathic pulmonary fibrosis to try to understand if we undergo a PET scan at time point 0, does that help predict what's going to happen 12 months from now? And we have preliminary data to say, well, perhaps it might. And if you look at a patient, this is a patient who had subsequent stable disease over the following year. There's a little uptake, but not much. And this is a patient who had progressive disease, as detected by the amount of change in pulmonary function. And you can see that there are more bright areas. And if we quantify that, you'll see that patients who had progressive disease kind of had a higher signal in the lung than those that did not. And this is work that I've been a part of that we're very excited about. Just thinking about these concepts of accelerating new therapies. I had a good fortune of work using this PET probe in a trial of an investigational IPF therapy. And we enrolled individuals who underwent the collagen PET imaging before being started on 12 weeks of an investigational therapy or placebo. And then we imaged them again at 12 weeks. And what we found is that our findings suggest that we are detecting a treatment effect. I say suggest because the numbers are very, very small. There were 7 individuals in the active treatment group, 3 individuals in the placebo group. But you can see here, these are the patients in the active treatment group. They had a slight decrease in the amount of signal compared to the individuals in placebo that had a slight increase. You'll see that there's one outlier here. This individual developed COVID in the first month of treatment, and also had a marked reduction in adherence to study drug. And so that is that outlier. But if you look over here, these images, this is an individual that underwent active treatment. And the brighter, the whiter, the more yellow is higher collagen. And you can see that the changes in the color in the lungs favor reduction in collagen. And this is a placebo participant, and the changes in the color in the lungs favor an increase in collagen over time. So these suggest that that kind of this approach of trying to measure the magnitude of wound healing responses um, might be able to inform short-term effect of investigational treatment. And then going back to the unmet needs, we talked a little bit about, predicting for patients that have established disease, how quickly their disease might progress. But what about going a little bit further? How can we predict who is going to develop pulmonary fibrosis? And these have implications for patient care and clinical trials. And if we go back to the schematic that I showed earlier in terms of priorities for pulmonary fibrosis research based on a workshop that was held in 2023, or actually a workshop that was held actually 2022, early disease risk factors and diagnostics have been recognized as a really important need to try to better hone for individuals that are at risk for pulmonary fibrosis, like family members and first-degree relatives. What can we do to better understand who might develop pulmonary fibrosis? And you need this information if we're going to go a step further and try to tackle prevention. So pulmonary fibrosis is currently diagnosed after considerable scarring has occurred. And theoretically, if you diagnose pulmonary fibrosis early, you should improve outcomes, although this has not yet been shown. And if you could better predict which individuals will develop pulmonary fibrosis, you could design a trial to focus on prevention. This is a trial that has being run through Colorado, and this is advancing prevention of pulmonary fibrosis study. These are individuals with family members with pulmonary fibrosis at increased risk who are increased risk developing pulmonary fibrosis. And this study is enrolling individuals with 2 family members with pulmonary fibrosis. Enrollment is complete. But the design is really to learn about factors, both genetic and environmental, that lead to early pulmonary fibrosis. And the thought is if we can better understand in whom and why pulmonary fibrosis develops, this may lead to treatments in order to prevent. So I will stop there and give us some time for questions. So thank you for having me, and I appreciate everyone listening.
That was really, really great. Thank you so much for all of that information. I know our audience today has some great questions for us. So if you're ready, we'll try to get to some of those. I have questions too, so maybe I'll get to ask some of my own questions. Um, Sydney, I'm going to go back to when you were talking about trial design. We had a question about if you could talk a little bit more about, you were talking about serial monitoring and the value of something not necessarily as a point in time, but over time, and how that might look for CT scans. And maybe you could talk a little bit about some of the things that we're not quite ready yet to use, such as quantitative CT and some things like that.
Yeah, that's a good question. So CT is a mainstay of diagnosis of pulmonary fibrosis. So there are a lot of advantages of thinking more how you incorporate CT in terms of clinical trials because it's really the cornerstone of clinical care. The problem with CT as we have now is that CT reads are dependent on the human eye, and not that the human eye is not good, but there's a lot of variability in terms of one person's progression is another person's stability. And when I look at a report, I'm looking at a radiology read. Um, and and so there's what Amy's talking about. There's a lot of interest in developing quantitative means of analyzing CT. And some of these are just based on measurements of different structural changes in the lung. And some of these ways kind of use artificial intelligence to try to pick up patterns that the human eye can't pick up. But several recent trials, phase 2 trials, have used as a secondary endpoint. So when I say secondary endpoint, these that's not the main reason for doing the trial, but they're considered supportive endpoints and looking to see if these medications, if you can actually measure changes in the amount of fibrosis. The one issue with that is, as we consider it now, it's thought that pulmonary fibrosis does not get better. Although if you use molecular probes, it's possible that those changes could get better if you're actually targeting a process. So you think about how you're looking at change over time in terms of if the amount of fibrosis was 10% on the imaging when you start, and then it went to only 11% on treatment versus 15% on not treatment, that is that potentially could be an important response. So there's a lot of work being done there. There's a lot of recognition that that of the need to collaborate amongst trialists, amongst communities, amongst registries, to really try to figure out, is there one best algorithm? And there might not be one best algorithm, but it would be helpful to have some standardization of how things are collected, because it will help benchmark trials in the future. Because if you have, a whole potpourri of chocolates you can pick from, just having some framework that you can try to benchmark your findings against others, I think that's when you start to make progress. So that might be a little bit more, I might have been a little bit more divergent in my answer than you wanted, Amy, but that's kind of what I think about.
I think that's great. I think it's a really interesting area, and I'm excited to see how we can develop, but also, again, coordinate so that you're making the right comparisons, and that you can, I think, understand what is the best way to go forward with some of these things. So I think it's a really exciting area. I have a lot of questions. I'm gonna knock down several of our audience's questions, with one ask for commentary about green tea and EGCG. I'm sure you get this question frequently given the involvement in the research. But essentially, I think people would like to know a couple of things. One, should they be okay drinking green tea or not? Um, should they try to, outside of a clinical trial while the data is pending, just go ahead and start taking EGCG? And let me see if there's another aspect to that. But I think that's kind of the gist of several of our audience questions, if you could answer.
Yeah, no, I think the EGCD is very interesting. Obviously, I'm biased because I work on it. I guess a couple of things. So people have been drinking green tea for thousands of years without, any significant appreciable side effects. So it's not thought to be harmful. Now, the reason why we're doing this study, aside from looking at drug effect, is also there have been, just to see if you're taking medications, how they could potentially interact with medications that are known to have an effect on IPF. So if we look back at the data I showed you before, in terms of the Panther study, I think no one thought that that triple therapy with prednisone, azathioprine, and NAC was going to be harmful, because if they thought it would be harmful, patients wouldn't have been prescribed it for years without it being studied. So I myself, as a provider, I can't recommend that people start, or I can't prescribe a non-studied therapy, because I think as a community, as a provider, we've been humbled by treatments that we didn't necessarily appreciate the full burden of risk. Now, again, this is this is a green tea extract, so, people might think about it different. The other thing I would say is this whole kind of one size fits all concept I talked about before. If you look at the NAC data, when you looked at studied NAC, placebo versus NAC, there was no effect. But if you divided it up between a gene type, there was one group that had the suggestion of harm and one group that had a suggestion of benefit. So all this being said, I think I am of the mindset that the best a benefit for our community would be to be enrolled in clinical trials. So if acknowledging that, if that's within, a patient's interest and their bandwidth and all that, because I think if we have more information in a structured fashion about safety, it helps move the field forward. And I might sound like I'm hedging in people's responses, but the real reason we're doing this study is try to answer these questions, so to speak.
Yeah, I think that the Panther story, the prednisone azathioprine story, is a real cautionary tale. And so I go back to that as well when I'm thinking about these things, particularly what you were just echoing, the NAC and acetylcysteine is over the counter. It's fairly unregulated. It seems pretty harmless. But there is concern that some of the subgroups of patients might not have done as well on it. We don't know that. It's not for sure, but is it worth that risk? And so I think that is an interesting. Um, I think that's an appropriate way of thinking of it from the scientific and medical perspective. Um, I I wanted to ask a question about pragmatic trial design, and your thoughts on ways to make clinical trials more accessible to our patients. We know it's really only a small fraction of the pulmonary fibrosis patients that are out there in the world that are even able to be part of clinical trials. How do we lower some of those barriers and make them more accessible from a trial design and pragmatic standpoint?
Yeah, it's a really important question because the more accessible we can make the trials, the broader the diversity and the patient population we have recruited, and then the greater confidence we have in the results might be applicable to more people. Um, ways to think about that are going to be opportunities to kind of decentralize some of the measurements. Um, newer therapies that are kind of coming through development. This is a little bit harder, especially when you have a number of standardized safety assessments such as EKG or blood tests. But when you're talking about repurposing treatments that might have been in use for many years for, let's see, cardiac reasons or things like that, then I think you have opportunities to do these pragmatic studies where you capitalize on your wealth of knowledge in terms of safety, and then you can do things like remote visits, work with a lab company like Quest so you can get local labs for the patient. One thing that I've been a part of is with Fernando Martinez and Bhavika Kaul, who works out of the VA, is we put in a proposal to the Department of Defense about proposing a phase 3 trial to do metformin. And we don't know yet if it's going to get selected for funding, but the thought behind this is that as a whole, clinical trials have not enrolled through the VA, and there are a large population of individuals that carry a burden of pulmonary fibrosis that have not had the opportunity to participate in studies, and trying to see, can we first use a repurposed therapy like metformin that is widely used and the side effect profile is known, such that we wouldn't have to do as many study visits as one would with a new treatment that's first in humans. And then can you build an infrastructure that's similar to what the Pulmonary Fibrosis Foundation has done with some clinical trials, and be able to have an infrastructure that allows recruitment of individuals for more rural communities. And so I think the answer to your question is twofold. One is, or actually probably threefold, is one, we need to capitalize on have a system for virtual visits and virtual lab collection. Two, we need a better way to be able to get spirometry remotely. People have been working on home spirometry, which does have some challenges, but people are trying to kind of understand that better. And then three, medications that have a more well-known safety profile, like metformin, things like, EGCG, NAC, medications like that kind of lend themselves to be able to use local labs in a way that a new first in human or phase 2 study using, an IV infusion would not.
Absolutely. Sydney, thank you so much for discussing these questions. There are others. I wish we could get to everyone's, but we are out of time for our session today.